Right. I think
Quite St. Jude.
St. Luke. Well, I think we'll move on quite quickly from St. Luke, if we may, to something which I think he would have approved of, which is personalised medicine. He was, of course, a physician, St. Luke. I hope that's helpful, Bruce, as a segue into the next paper.
Thank you, Chairman. Since you want to take this back into the Dark Ages, perhaps I could start with a remark from Darwin, who in many ways spawned the interest in genetics and what have you. He said that it's not the strongest of the species that survive, nor the most intelligent, but the most responsive to change. And I think that kind of sets the scene for the discussion, because when I look at the drivers for change in healthcare systems around the world, number one is going to be economics. The second is going to be an interaction between science and technology, particularly information technology, then a set of public, professional, and political expectations, and then some demographics. But one of the things that strikes me is that we can solve many of the issues which face us if we're responsive to the emerging changes in science and information technology. And England, in my view, has got a remarkable heritage to harvest in this area. So we have Darwin, who exposed, I guess, the theory of evolution in the 1850s. In the 1950s, we had Rosalind, Franklin, we had Gosling, Watson and Crick, Wilkins, discovering the structure of DNA. And then in the mid-1970s, up in Cambridge, we had Sanger really setting the basis for the sequencing of DNA, which means that we've got the strongest track record of understanding this, I guess, of any country in the world. And through Genomics England and the 100,000 Genome Project, we are now in a commanding position to lead the world in the sequencing of the human genome. And it would be a shame not to bring the benefits of that scientific endeavour to the patients of the NHS. And there is an opportunity to exploit this. And by that, I mean that understanding the genome and understanding its relationship to human disease, we can, in relatively short order, I guess, get to a place where we can predict the predisposition of people to certain diseases. That will enable prevention or delay of the disease through interventions. It'll take us to more precise diagnoses, and by that I mean when I trained as a surgeon, there were 4 different types of breast cancer. Now there are over 40. There was just adenocarcinoma of the lung, and now there are many different types, all defined by their genetic sequence. And understanding that enables us to target treatments in a way which is far more precise and, as a consequence, far more accurate, and it reduces waste in terms of ineffective treatments. Now, this only works. We can only do this if we have laboratories around the country that are capable of undertaking the sort of analysis that's required. We've made some progress on that through Genomics England, and NHS England. We've established 11 genomics medicine centre labs. We're about to go through to re-procurement of the genetic laboratory system, and we have a unique opportunity there to link those in a way that's harmonised and efficient, and we will drive that through the commissioning system. The other thing that we have to consider is how we link genomic information with other information about patients, and that takes us into the information technology arena and also into some strong information governance territory. But it also takes us into a space where I think we need to start thinking about how we use much greater use of mobile technology, not only for this highly specific information, but for the exchange of healthcare information more generally. But with respect to the role of genomics, which this personalized medicine strategy paper is about, the third issue that we really have to address is how we train staff to analyse, understand and affect the emerging results of this sort of endeavour. So this paper is really a placeholder which asks for the board's approval for us to go away and undertake a focused piece of work to try and develop a 5-year strategy for the NHS about how we might exploit the emerging science and technology, and come back to the board with emerging thoughts for that strategy in the relatively near future.
Thank you, Bruce, for that introduction. Let me invite comments and questions from members of the board. Victor or John?
Perhaps there is a notion in relation to this that it's more about something about the ethical and access issues. So, for instance, how do we know that access to this amazing technology across all the diseases that affect different people, different races, different social classes will be addressed with a kind of equal... How do we avoid the inverse care law, basically? How do we ensure that we avoid the inverse care law as we bring in this new technology?
Well, we avoid it at this point by raising the question and writing it into the way we solve the problem.
Because it seems to me that when you do your piece of work, I would be interested in knowing that's part of our role in rolling this out. That we seek to address the inverse care law in our approach, and I think it was just a bit missing.
I think, in a sense, to comment and address that. I mean, obviously, my professional involvement in this has been lifelong, so I'm excited to have it discussed here. And I think the answer is that the genomic medicine centres are being built upon a very long-established network of regional genetic services, and they are extrapolating out into their local medical communities. So the answer is we've been doing this for a long time, but now it's just expanding in its impact. The one reassurance I would have for the board, I think the one anxiety we have when we start talking about personalised medicine, in a sense which is under your comment, is that we end up with an increasing demand and people more and more wanting themselves tested and so on. I think that this is where the NHS actually will come into its own, because it's very obvious that having a free at the point of need system makes it possible for us to deploy this sort of technology in an acceptable way, and that the fears about data management and so on are far less in our country than they are in most other countries. So I think that puts us in a very strong position. The other reassurance, I think, is that when you actually, I know, because there's been one very good study from health economists in Essex where predictive testing in colon cancer, where I have my main interest, has been demonstrably shown to be a cost saver. That in fact, if you can identify and target and specifically treat tumours according to their underlying cause, then you both prevent and treat more effectively. So this is a cost-saving intervention, but we shouldn't underestimate the disruptive impact of introducing it because of the informatics and everything else. But it is worthwhile, and it will save money once it's in place.
No.
I wholly support Bruce's initiative to try and bring the strategy together for personalised medicine, and while it is crucially genomics, it's also, as you said, much more than genomics. I support it for many reasons, but one is that there are a number of initiatives already underway that are related to this, not least the Accelerated Access Review that the government's commissioned, plus our own incubators, which is a number of startups which are dealing with parts of this. In that review, what role do you see for the AHSNs? And I'm particularly thinking of whether they can take more responsibility and more leadership in the system around how we deliver personalised medicine into the population. Because there are two sides to the coin. There's the design side and the delivery side. And I'm really interested in how proposals will come forward for making a difference to the population once we have invented the clever drugs and devices?
So, for those that aren't entirely familiar with the HSNs, there are 15 academic health science networks around the country. They are geographically disposed in a way that they encompass particular sets of patient flows. So they contain a particular set of patient flows. The idea with the academic health science networks was that they would become an innovative engine for the NHS, that they would bring together people with interests in healthcare, whether that be providers, commissioners, local authorities, industry, so on and so forth. And we see them as powerful agents for change. The issue for this particular endeavour is that not all academic health science networks are the same. So different networks will have different focuses, but there are some that would be very well equipped to help roll out personalised medicine, in the sense that they have a greater grasp, if you like, of genomics and genetic medicine than others. So that, I think, would be part of the deliberations which we would go through, given that the board has, well, hoping that the board will approve this paper.
Bruce, in my world, this would be classic case of test and learn. Try lots of things, test them, see how we can learn, stop things quickly, so fail fast. And I guess the question is, have we got that type of mentality, but also have we got the capability and resources to allow us to really understand and capture that learning and disseminate it quickly, which is as much about behaviour as well as it is about resources and capability.
I think because this is so new, that we can easily write in the fail fast and learn as quickly as we can. I don't see that as a particular issue, particularly not if we're using HSNs and other small geographical areas for testing. In terms of resources required, I think that's an issue for future deliberation. So the aim of this particular paper was simply to seek permission from the board to proceed with a series of work streams, of which understanding the resourcing would be one.
I did think about whether I should register a conflict of interest at the start of the meeting with my new role, Malcolm, but I decided that it was a mutuality of interest. And I think this is an area where it is indeed. And as I've started the new job, I've sort of looked across where collaboration is working well. Bruce, I mean, it is working really well with medical directors of Monitor and TDA, thanks to you and others. It would be really helpful to make sure that my new colleagues are heavily engaged in this, representing the communities that they represent with you going forward. So I hope that's the case.
That would be fantastic, and it will become the case.
Thank you.
Right, well, thank you. I think that it's necessary to understand that this is not England heading off on its own. This is a global phenomenon. The whole move towards personalised medicine, or precision medicine as it's sometimes called, the relationship between whole genome sequencing and other occurring and developing technologies. I take David's point about it being test and learn. In fact, the 100,000 genome project is very much in that territory, and it'll take us some while to work out what we've learned from it. But we, from our perspective, have always seen it not as a research project, which it is in part, but actually as an NHS transformation project, and how we can maintain an important lead in the world in developing genomic medicine as a transformation of the way in which medicine is practiced. So in that space, I think the work of the 11 genomic medicine centres that we have designated is absolutely critical. And I think it's important that the board understands just how difficult this has been. I think for 2 or 3 reasons. One is that this is really leading edge stuff, and even just getting the samples for delivery for sequencing has proved quite complicated, because this is the first time it's been done on this scale. For rare diseases, it's been a bit more straightforward, but for cancers, it's still quite challenging. And we are not quite where we would wish to be on the volume of samples, and a lot of work is being put into that to try to develop it. And I think I would like today to pay credit to the GMCs and what they're doing, but urge for a little more and speeding up of the submission of samples. But secondly, it's not just the technology, it's the culture change that this has started to introduce across the GMCs, and more broadly infecting the work of the NHS providers. It's the concentration on deep phenotyping, of providing clinical data without which the genotypic data is not of great value. And then the capacity through the 100,000 genomes project of looking at large numbers and being able to spot patterns and being able to learn from that. So it really is quite transformational. But as always, the technology's importance starts to subside as the cost of the technology also starts to subside. And it's the practice of medicine and the cultural change that flows from it that I think will be of great value to us. Questions have been raised about what's the cost impact of all of this, and will it save us money? I think one always has to be cautious about new technologies in medicine and how one assesses the return. But if we can succeed in the way in which the paper suggests in heightening prediction and prevention, then there are significant gains to be had, and I think John has made that point very effectively. So may I commend the paper to the board and ask you to agree the principles that it proposes, and to endorse the proposal that work be taken forward to develop a personalised medicine strategy for the NHS. Happy to do that. Thank you very much.